Welcome to the Language Clinic channel. It's a channel of education. It's a channel of entertainment. Education is entertainment. So, if you are the first viewer, first watcher, if you are watching first, please subscribe the channel. Please like and comment. We will talk about LV dysfunction and dilated cardiomyopathy and their etiologies and evaluation. We will talk about several questions and the answer to the dilated cardiomyopathy and heart failure. Question number 1. What is the definition and incidence of heart failure? The answer is heart failure or HF is a clinical syndrome resulting from progressive myocardial dysfunction that compromises ventricular filling and cardiac output. HF patients may be broadly categorized as having HF with preserved ejection fraction, in brief HF-PEF, defined as left ventricular ejection fraction more than 50% to 55%, or patients who have heart failure with reduced ventricular ejection fraction, HFrEF, defined as LVEF less than 40%. Heart failure phenotypes have been further stratified to include HF with mid-range ejection fraction or simply HF MEF, LVEF less than LVEF 41% to 49%, which has overlapping disease features and intermediate prognostic implications to that of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Heart failure with mid-range ejection fraction patients may include de novo heart failure and a continuum of disease on the basis of LVEF. Categorical distinction is important as there are established therapeutic interventions from large clinical trials for patients with LVEF less than 40%. However, there are no specific therapies of proven benefits for patients with heart failure with preserved ejection fraction. The lifetime risk of developing heart failure is approximately 20%, and the incidence increases with age. Overall, survival has improved for heart failure. However, absolute mortality remains high at 50% within 5 years of diagnosis. Now, question number 2. What is the major pathophysiology of heart failure with reduced ejection fraction? The answer is, despite different etiologies for heart failure with reduced ejection fraction, the compensatory mechanisms, pathophysiology, and maladaptive responses to LV dysfunction are similar. A primary insult to the myocardium, myocardial infarction, myocarditis, genetic mutation, toxins, etc., leads to depression in LV systolic function and decreased systemic blood flow. The initial neurohormonal response activates the sympathetic nervous system and the renin-angiotensin aldosterone system RAAS to maintain systemic perfusion through vasoconstriction and sodium and fluid retention. However, prolonged activation of the RAAS or RAS pathway is deleterious and leads to adverse cardiac remodeling, increased cardiac fibrosis, and inexorable disease progression. Evidence-based pharmacologic therapies in heart failure powerfully target these pathways to stabilize disease and promote reverse remodeling. Question 3. What is dilated cardiomyopathy? The answer is, dilated cardiomyopathy or simply DCM is a unifying term describing myocardial dysfunction with progressive LV wall thinning and dilation and reduced LVEF in the absence of abnormal loading conditions. That means hypertension or valvular disease. DCM is the most common form of cardiomyopathy. It represents a shared phenotype for a myriad of cardiac disorders that lead to myocardial damage and chamber dilation. Question number 4. What are the common causes of DCM or dilated cardiomyopathy? Causes of DCM include genetic causes, toxins, infection, inflammatory disorders, and collagen vascular diseases, nutritional disorders, pregnancy, also termed peripartum cardiomyopathy or PPCM, endocrine disorders, tachycardia induced cardiomyopathy, and stress induced cardiomyopathy. Question number 5. How does DCM present? The answer is typical presenting symptoms of DCM include exertional dyspnea, fatigue, reduced exercise tolerance, weakness, orthopnea, paroxysmal nocturnal dyspnea, weight gain, early satiety, nausea, bendopnea, and lower extremity edema. Physical examination is notable for elevated jugular vein pressure or JVP, extra heart sounds, S3, S4, pulmonary congestion, and lower extremity edema. Physical exam signs that are most specific and associated with poor prognosis include elevated JVP or jugular vein pressure and an S3 heart sound. With disease progression and development of right-sided dysfunction, patients can develop ascites, hepatomegaly, cardiac cirrhosis, and worse, cardiorenal syndrome. In advanced heart failure, cardiac cathexia may develop and which manifests as muscle loss, temporal wasting, and higher degrees of frailty. Question number 6. What diagnostic testing is part of the initial evaluation for patients with newly diagnosed DCM? Answer is a thorough history and physical examination should be performed on all patients with incident heart failure, as this often provides clues for etiology. DCM may be genetic and or acquired. A careful family history and review of risk factors and toxic exposures must be obtained. The recommended initial diagnostic testing includes a complete blood count, comprehensive metabolic panel, fasting lipid profile, urine analysis, thyroid stimulating hormone or TSH, natriuretic peptide levels or B type, natriuretic peptide or BNP, or N-terminal pro-BNP, pro-type, pro-B type natriuretic peptide or NT-pro-BNP. Cardiac enzymes, chest radiograph, electrocardiogram or ECG, and echocardiography. So that's all about the answer of question number 6. Now question number 7. What is the role of cardiac imaging in diagnosis of LV dysfunction? Transthoracic echocardiography or TTE is a widely available first-line imaging test for newly diagnosed cardiomyopathy. In addition to quantifying LVEF, it provides valuable prognostic information such as degree of LV dilation, chamber geometry, regional wall motion abnormalities and wall thinning, valvular function, diastolic function, and right ventricular assessment. It may also identify LV apical thrombus formation. TTE or transthoracic echocardiography is frequently used in serial assessments of LVEF if there is concern for clinical worsening, to evaluate response to medical therapy, and to determine candidacy for device therapies such as implantable cardiac defibrillator or ICD, or cardiac resynchronization therapy or CRT. A newer application of TTE is strain imaging. Global longitudinal strain assesses the myocytes' ability to deform or shorten in the longitudinal plane, which is a marker of both systolic and diastolic dysfunction. Strain imaging is being used to monitor patients undergoing cardiotoxic chemotherapy, as reduction in LV strain can precede LVEF decline and should prompt initiation of cardioprotective ASF guideline-directed therapy. Advanced imaging techniques such as cardiac magnetic resonance imaging or CMRI are increasingly valuable in the evaluation of new DCM. CMRI is considered, or simply cardiac magnetic resonance imaging is considered the gold standard for assessing biventricular EF and volumes, and is advantageous for identifying myocardial tissue characteristics with late gadolinium enhancement or LGE and oblique or T1 mapping. CMR is a highly sensitive, non-invasive test for diagnosing specific infiltrative cardiomyopathies, which often have pathognomic LGE patterns, as well as for assessment of myocarditis, arrhythmogenic right ventricular dysplasia, and quantifying myocardial scar or fibrosis. Additionally, CMIRI may overcome the diagnostic limitations of endomyocardial biopsy sampling for infiltrative or restrictive cardiomyopathies. It is highly recommended to consider cardiac MRI in patients with cardiomyopathy of uncertain etiology. Question 8. Do all patients with new LV dysfunction or DCM require an ischemic evaluation? The answer is, since coronary artery disease or CAD is the most common and reversible cause of heart failure, patients with angina symptoms or CAD risk factors may require invasive coronary angiography. Often, DCM patients may have normal or mild non-obstructive coronary disease that is insufficient to explain the degree of cardiomyopathy. Computed tomography or CT angiogram is an alternative given its high negative predictive value. However, it carries similar risks of radiation and contrast administration as coronary angiogram. Stress echocardiogram and nuclear stress testing may be used to assess for inducible ischemia. However, these modalities may underestimate degree and severity of CAD or coronary artery disease. Question number 9. What's the role of an endomyocardial biopsy in the diagnosis of LV dysfunction? Answer is, endomyocardial biopsy or EMB of the native heart is not commonly indicated in the evaluation of newly diagnosed heart failure and should only be performed in specific clinical circumstances in which EMB or endomyocardial biopsy results may meaningfully modify prognosis or guide treatment. Biopsy results may often be non-specific or unrevealing in DCM. There are two scenarios in which EMB or endomyocardial biopsy is a class 1 recommendation for the guidelines 2007 American Heart Association or American College of Cardiology or ESC guidelines, where a biopsy should be performed, number 1, for patients who present with unexplained acute less than 2 weeks heart failure and evidence of hemodynamic compromise, and 2, for patients with new heart failure within 2 weeks and 3 months of duration who present with a dilated LV and new ventricular arrhythmias or high degree and atrioventricular or AV blow. and oblique or who fail to respond to standard medical care. A biopsy is helpful in patients with suspected giant cell myocarditis, which carries a significantly worse prognosis with risks of hemodynamic deterioration compared to lymphocytic myocarditis, which has a greater likelihood of recovery. Question number 10. What's the role of right heart catheterization in patients with newly diagnosed and chronic DCM? Not all patients presenting with a new heart failure or DCM require an invasive measurement with right heart catheterization or RAC to determine their hemodynamic profile. However, in patients with acute decompensated heart failure, progressive dyspnea, poor perfusion on clinical exam, worsening end organ function, and oblique or poor response to medical therapy, that is, worsening renal injury with diuresis attempts, and RAC may provide critical information on biventricular filling pressure elevation and cardiac output that allows for effective hemodynamically tailored therapy. Additionally, RAC permits assessment of pulmonary hypertension or PAS severity, which develops from long standing left sided heart failure and is associated with worse prognosis. Approximately 40% to 75% of patients with heart failure with reduced ejection fraction have coexisting PAs, often passive pulmonary venous hypertension versus mixed PAs with combined pre and post capillary PAs. All patients presenting in new heart failure with cardiogenic shock warrant continuous hemodynamic monitoring to guide therapies and escalate temporary mechanical circulatory support accordingly. Sorry. Question 11. What is the diagnostic and prognostic significance of biomarkers in LV dysfunction? The answer is the most commonly studied biomarkers in ASF are BNP or NT-proBNP. BNP is generated by myocytes during excessive myocardial stress. The measurement of these biomarkers is important in the diagnosis of heart failure and guides prognosis. In patients with known heart failure, an elevated BNP is associated with worse clinical outcomes, and a decrease in BNP with therapy is associated with improved outcomes. Given this correlation, many trials use biomarker endpoints as a surrogate for clinical outcomes. It's important to note certain conditions that impact BNP independent of heart failure, renal failure, age, sepsis, and atrial fibrillation are associated with increased BNP. Obesity is associated with decreased BNP. Question 12. What are common genotypic phenotypic associations in DCM or dilated cardiomyopathy? The answer is as genetic testing has become more extensive and accessible, it is now evident that 25% to 30% of DCM cases are familial in origin. Many pathogenic genes encode for sarcomere proteins, cytoskeletal proteins, calcium handling, and nuclear membrane proteins that are integral to myocardial structure and function. Although more than 40 genes have been identified, disease penetrance varies widely, and there are likely epigenetic factors, that is, environmental, viral, and oblique or immunological factors that play a role in DCM management. The most common genetic abnormality involves mutations encoding the largest protein in the human body, the sarcomere protein titin or TTN. Many genetic mutations lead to variable phenotypes, but there are some that have consistent genotype phenotype associations. LMNA encodes nuclear proteins lamin AC. Mutations are associated with arrhythmias, that is AV block, supraventricular and ventricular arrhythmias, and muscular dystrophy, limb girdle emery diffuse. The yield of genetic testing is increasing with time, and a disease causing mutation in the proband can be used to screen first degree relatives. If no causative gene is found, all first degree relatives are recommended to undergo echocardiograms every 3 to 5 years. Question number 13. What are the features of acute reversible cardiomyopathy, that is stress induced or Tacos, Takotsubo's cardiomyopathy? The answer is stress cardiomyopathy or Takotsubo's is characterized by the acute onset of LV dysfunction in the setting of emotional or physical stress like surgery, trauma, sepsis, intoxication, etc. Patients present with chest pain, shortness of breath, ECG changes, T wave inversions, ST elevation, and QT prolongation, and wall motion abnormalities on echocardiography. The most common wall motion abnormality involves apical echinacea with basal hyperkinesis, apical ballooning syndrome. Takotsubo's is a diagnosis of exclusion and requires a coronary angiogram to rule out obstructive CAD due to the presence of wall motion abnormalities with ECG changes. Invariably, LVEF recovers usually between 1 and 2 weeks. However, it can be delayed up to 6 weeks. Interestingly, recurrences are common up to 20% at 10 years, and more research is needed to identify cardioprotective interventions to reduce future risks. Question 14. What are the features of toxin mediated cardiomyopathy? Answer is alcohol is a direct cardiomyocyte toxin and leads to DCM when chronic heavy alcohol use occurs approximately 5 drinks daily for more than 5 to 10 years without other identifiable heart failure cause. Alcohol abstinence can partially or completely reverse the DCM. Without abstinence, overall prognosis remains poor with a mortality of 40% to 50% at 3 to 6 years. Other causative toxic substances include cocaine, amphetamines, clozapine, hydroxychloroquine, cobalt, and lead. Question 15. What are the features of chemotherapy-induced cardiomyopathy? Chemotherapy-induced cardiomyopathy is defined as LVEF reduction of at least 5% with symptomatic heart failure or 10% with asymptomatic heart failure to an LVEF value less than 50%. Reduction in global longitudinal strain may precede a reduction in LVEF. The most prominent chemotherapy agents implicated in cardiomyopathy are anthracyclines and trastuzumab SERTR2 inhibitor. With anthracyclines, the cardiotoxicity can occur only early during therapy or 10 to 20 years after therapy and is partly dose dependent. The traditional cutoff is 550 milligram per meter square. However, cardiotoxicity can happen at much lower doses. Trastuzumab causes a non-dose related cardiomyopathy and responds better to standard therapy than anthracycline-induced heart failure, with complete recovery seen within 6 months of drug discontinuation. Once cardiotoxicity develops, standard heart failure management consists of beta blockers and angiotensin converting enzyme inhibitors or ACEI. The optimal strategy for chemotherapy after heart failure diagnosis is challenging due to completing risks of cancer versus heart failure disease progression. Question number 16. What are the features of peripartum cardiomyopathy? PPCM or peripartum cardiomyopathy occurs in the last trimester of pregnancy or within 6 months following delivery. Other etiologies of DCM must be excluded when diagnosing PPCM. Risk factors include African American race, preeclampsia, hypertension, multigestational pregnancy, and older maternal age. Treatment during pregnancy includes beta blockers, hydralazine nitrates, digoxin, and loop diuretics. ACEI or angiotensin receptor blocker or aldosterone antagonists are contraindicated during pregnancy. However, after pregnancy, ACEI or enalapril, enalapril or captopril and aldosterone antagonist can be used in breastfeeding mothers. Of note, there is a higher incidence of thromboembolism in patients with PPCM. Therefore, it is recommended that these patients receive systemic anticoagulation since prolactin is involved in the pathogenesis of PPCM. Bromocriptine has been postulated to be a possible treatment option, although data are presently limited to support widespread use. PPCM has been associated with a more favorable prognosis and higher rate of LV discovery compared to other forms of heart failure, usually occurring within 3 to 6 months. However, African American females showed a lower rate of recovery. For patients who recover their LVEF, there is risk for developing PPCM again during subsequent pregnancies, and patients should be counseled accordingly. Patients who have not recovered their LVEF are at high risk for poor outcomes, and subsequent pregnancies are discouraged. Question number 17. What are the features of tachycardia mediated cardiomyopathy? The answer is tachycardia induced cardiomyopathy occurs due to persistent tachyarrhythmias with elevated ventricular rates. The most common arrhythmias associated with this condition are atrial fibrillation and atrial flutter. However, any long-standing tachyarrhythmia, atrial tachycardia, AV nodal, reentrant tachycardia or AVNRT, accessory pathway mediated reentrant tachycardia or AVRT, sinus tachycardia can cause LV dysfunction. The treatment involves not only standard guideline directed medical therapy GDMT but also aggressive treatment of the underlying tachycardia. The elimination of the tachyarrhythmia usually leads to recovery of LV function. However, it can take up to 4 to 12 weeks. Many of these patients are at risk for recurrence, which leads to a more rapidly progressive heart failure course compared with their initial presentation. Question number 18. What guideline directed medical therapy is indicated for the initial management of LV dysfunction? The answer is GDMT in initial heart failure treatment is similar as for chronic stable heart failure. Multiple medications have favorably impacted survival through modulation of the neurohormonal pathways that are activated in heart failure. Standard medical therapy includes beta blockers and ACEI depending on LVEF and functional status. Treatment may also include aldosterone antagonist, hydralazine isosorbide dinitrate, angiotensin receptor, neprilysin inhibitors or ARNI or ARNI, and most recently sodium glucose cotransporter 2 or SGLT2 inhibitors. Diuretics aid in symptom relief from volume overload but do not have mortality benefit. In patients with a coexisting atrial fibrillation and previous cardioembolic stroke, especially if suspected in severe LV dysfunction or if LV thrombus is visualized on echocardiography, anticoagulation is also warranted. Question 19. What is the current heart failure staging and classification system? Answer is patients with new LV dysfunction and heart failure are classified according to American College of Cardiology or American Heart Association stage A to stage D, which has direct therapeutic and prognostic implications. In conjunction with ACC or ASA stages, the New York Heart Association or NYSA functional class FC is used to determine functional status based on symptom severity. Question 20. When is device therapy like ICD or CRT recommended in patients with DCM? ICD is routine in patients with DCM and prior sustained ventricular arrhythmia or sudden cardiac death. ICD implantation for primary prevention is a class 1 recommendation for patients with LVEF less than 35% and New York Heart Association class 2 or 3 symptomatic symptoms on chronic ZDMT for at least 90 days with life expectancy more than 1 year. And CRT, also referred to as biventricular pacing, has been shown to improve LVEF symptoms and mortality in patients with electrical dyssynchrony and DCM. CRT is a class 1 recommendation for patients with LVEF less than 35% in sinus rhythm with left bundle branch block or LBBB and QRS more than 150 milliseconds on optimal medical therapy. And New York Heart Association FC23 or ambulatory 4 symptoms. CRT may be considered in patients with LVEF less than 35% and LBB with QRS duration to 120 to 149 milliseconds. So that's all about LV dysfunction and dilated cardiomyopathy and their etiologies and evaluation. So this is all in brief about dilated cardiomyopathy or DCM. I hope you have enjoyed listening to this, and if you enjoy listening to this, this is a channel of education. Education is entertainment. So this is a channel of entertainment. Education gives us entertainment. Education gives us power. Education gives us strength. Education helps us to live better, to live smarter, to live longer. So if you like this channel, you can subscribe to this channel, you can like, and you can show your comments here. So wishing you all a good health. Thank you. Bye bye for watching this.